Hello, everyone. Welcome to another topic of the pathophysiology. Today, we're going to talk about the alteration in blood pressure. So, what is arterial blood pressure? The arterial blood pressure is the pressure within the arteries to promote the movement of blood in the circulatory system. It is a pressure that is produced by the force of your left ventricle contraction, and that contraction, the pressure has to overcome the resistance of the aorta to open the aortic valve. The determinant of the systemic blood pressure includes the cardiac output, which is the stroke volume times the heart rate. Also, you have the end diastolic volume, which is also known as the preload, which is the amount of blood that's returned to the heart. Another factor is the systemic vascular resistance, also known as the afterload, and that is determined by the radius of arteries and degree of vessel compliance. So blood pressure is then equal to cardiac output times systemic vascular resistance. You can measure the mean arterial pressure by taking your diastolic pressure, multiply that by 2, then add the systolic blood pressure, all divided by 3. That gives you your mean arterial pressure. Systemic arterial blood pressure. Once again, we said blood pressure is cardiac output times systemic vascular resistance. Cardiac output is the stroke volume times the heart rate. So what causes the heart rate or controls the heart rate? We have the beta 1 receptor stimulation by the sympathetic nervous system, and the stroke volume is the preload, which is caused by the myocardial contractility, which is stimulated by the beta 1 receptor of the sympathetic nervous system as well. For the radius, which determines the vascular resistance, you have the alpha stimulation, which controls the radial. Measurement of blood pressure. So the blood pressure, we have the systolic blood pressure, which is the peak pressure during the cardiac cycle. You have the stroke volume, which is the primary factor influencing the systolic blood pressure, and also increases the systolic blood pressure increases with age as the aorta and large artery loosen. The second factor in blood pressure is the diastolic blood pressure, which is the lowest pressure during cardiac diastole. Systemic vascular resistance is the major determinant of this diastolic pressure. And then we have a pulse pressure, which is basically the systolic pressure minus the diastolic pressure. So measurement of our blood pressure are taken by two different ways. One is called the direct, and the second, which is the indirect. The direct way method is much more invasive, which requires the intra-arterial catheter placed in the radial artery, and that is the most accurate method of measuring blood pressure. The second way, which is the way we do in the clinic, which is an indirect way, and that is measurement of the brachial artery using the stethoscope and the sphygmomanometer. For some reason, patients have this white coat effect, and what it is basically as they see the practitioner in a white coat, for some reason, their heart rate goes up and they get nervous. So that also influences the blood pressure. Blood pressure regulation requires participation of both the cardiovascular and the renal system. So on the left-hand side here, you can see that if you have an increase in blood pressure, that causes, or the increase in blood volume, which leads to an increase in blood pressure. When you have an increase in blood pressure, your body will try to compensate and bring that back to homeostasis, and that is through vasodilation and also decrease in cardiac output. With those two, then your body will decrease in blood pressure, and that is the cardiovascular response. On the right hand side, you're going to have a renal response, which is the slower method, and that causes the excretion of fluid in the urine, and then that causes the decrease in blood volume. Thus, it will cause a decrease in blood pressure. The other way that your body responds to blood pressure is through the baroreceptor reflex. So there are two areas in your body where they have a baroreceptor. One is the aorta, and the second one here, and here's the aortic. So what happened is that once these baroreceptor, which are pressure receptor, when they sense a decrease or an increase in blood pressure, then they will activate either the parasympathetic or the sympathetic nervous system to regulate your blood pressure. And that is to do what? Number one, it will then causes either an increase or decrease in heart rate and a vasodilation, vasoconstriction, and the contractility. Okay, so increase or decrease in contractility as well. So the renin-angiotensin-aldosterone system versus the atrionatriuretic peptides. So these are two of the systems that are actually does the opposite of one another. So as you know that the angiotensinogen is produced within your liver, and that floats around, and when you have a low blood pressure or hypotension, what happens is that your kidney will then produces renin. Renin, once it meets angiotensinogen, then it will activate angiotensinogen into angiotensin 1. Angiotensin 1, then it will be activated once again by another enzyme, which is called the angiotensin converting enzyme, also known as ACE, into angiotensin 2. Angiotensin 2 has two important functions. First is it is a very potent vasoconstrictor, and that vasoconstriction causes an increase in blood pressure. The second function of the angiotensin 2 is to release aldosterone. Aldosterone, as you know, would then cause a reabsorption of the sodium back into our vasculature, and with sodium, water will then come along, and that increases blood volume, thus will increase in blood pressure. Atrionatriuretic peptide does the opposite. So when your system senses an increase in blood pressure, then it will release atrionatriuretic peptide, which comes from the atrium of your heart. So this atrionatriuretic peptide will then increases the secretion of sodium and water by increasing the GFR, or the glomerular filtration rate. So hypertension is a very, very important topic. It is the most common primary diagnosis in the United States, and that's responsible for 7 million deaths every year worldwide. It increases the morbidity and mortality that is associated with the heart disease, kidney disease, peripheral vascular disease, and stroke. And as you can see here, back. Okay, so normal blood pressure, it is the under 120 for systolic and under 80 for the diastolic blood pressure. And that is contrary to what you see in the clinic, where the blood pressure, which everybody refers to as normal, is 120 over 80. And 120 over 80, according to this table, it is considered prehypertension. So prehypertension is when your systolic blood pressure is 120 to 139, or your diastolic blood pressure is 80 to 89. So we have stage 1 hypertension, and then you have stage 2 hypertension. Okay, so here you can see in this chart, it's really blurry. Okay, so ideal blood pressure, low blood pressure, high blood pressure. So, okay, so types of hypertension. We have a primary hypertension and secondary hypertension. Primary hypertension is also known as the essential hypertension, and it is an idiopathic disorder, which means that we don't know exactly what causes it. It is the most common form of hypertension, which causes 90 or 95, or it is accounted about 90 to 95% of all of the hypertension that is out there. It is very rare in children that is under the age of 10. So when you have the systolic blood pressure, which is the major risk factor for cardiovascular disease. Secondary hypertension is a hypertension due to a specific identifiable pathology or condition. The most common form in infant and also preschool hypertension. So there's an underlying disease or problem that causes this hypertension. It is also the most common cause for childhood secondary hypertension, and that is the renal disease and the coarctation of aorta. Risk factor of primary hypertension also includes family history, age, and genetics. The modifiable risk factor of primary hypertension includes diet, sedentary lifestyle, obesity, metabolic syndrome, elevated blood glucose, elevated cholesterol, and also alcohol and smoking. The primary hypertension risk factor for childhood and adolescent or intrauterine, when you have the maternal or mother who, when they're carrying the child, they're smoking. Second factor is the pregnancy-induced hypertension, dietary habit, low socioeconomic level of the mother, inadequate intake of calcium by pregnant mother, and also breastfeeding seem to reduce these risks. So primary hypertension, also sometimes called the silent killer, as it damages as the damage has already occurred to organ before the diagnosis is made. The outcome of the primary hypertension is end organ damage. Number one, when you have the heart, which has an increased myocardial work that results in heart failure. So you have cardio hypertrophy or myocardial hypertrophy, which is an increase in the heart muscle itself. You're going to have a stiff myocardium, and you're going to have valvular regurgitation, and also you're going to have VFib or ventricular fibrillation. The second factor in this end organ damage of the heart includes angina, which is chest pain, and that is mainly due to ischemia. Cardiovascular disease is the acceleration of atherosclerosis. You're going to have kidney damage, and that is due to glomerular damage, result in kidney failure. The eye, you're going to have the microcirculatory effect of the eyes, and also the brain, which has an increased pressure in the cerebral vasculature, and that can result in a stroke. And that will be the hemorrhagic stroke, and that occurs about 20% of all the stroke. The primary cause of a stroke will be the ischemic stroke, which is caused by the atherosclerosis within the cerebral vasculature. So treatment for hypertension is definitely the lifestyle modification. Lifestyle modification should be the first and foremost important prevention treatment strategy, and that is to lose weight, exercise, using the DASH diet, alcohol consumption limitation, and also decrease sodium intake, meaning that using less salt. The drug therapy affects, number one, you're going to have something that limits the stroke volume. You're going to have use a drug that also decreases systemic vascular resistance or decreases heart rate, and that will then bring down. So you have stroke volume. These are the types of drug. You have the diuretic, you have the loop, and the thiazide. You have the potassium sparing diuretics, aldosterone receptor blocker, ACE inhibitor, angiotensin 2 receptor blocker, and venodilator. And then here you have the drugs that will reduce the vascular resistance, okay? And then you have the one that reduces the heart rate. So secondary hypertension, adult secondary hypertension may be related to renal artery stenosis, pheochromocytoma, pregnancy, obesity or obstructive sleep apnea, and also hyperaldosteronism, which is the number one leading cause of secondary hypertension. It is correctable, curable by addressing the underlying cause, of course. The hypertension emergency and urgency. So hypertensive emergency is a sudden increase in blood pressure that is over 180 over 120 with evidence of end stage or end organ damage. So when you have a reduction of blood pressure by 25% or more during within the 8 hours, you're going to have a parenteral antihypertensive medication, which is labetalol, nicardipine, esmolol, in the ICU setting. And that is hypertensive emergency. Hypertensive urgency is similar blood pressure. However, you're not going to have the end organ damage. Without the end organ damage, the treatment will be an oral medication which brings blood pressure back under control in the time span of about 24 to 48 hours, whereas the emergency, you need to reduce that blood pressure by 25% within the 8 hours.